Hello and welcome back to Malaria Part 4. In Part 1, we tried to understand what is malaria and understand the treatment or prevention strategies developed. Part 2, we saw the treatment regimens, actual drug regimens for chloroquine sensitive malaria. And in Part 3, we have seen the regimens for chloroquine resistant malaria and falciparum malaria and the regimens used during pregnancy. Before going on to the details of individual drugs in this section, let us first revise quickly what we did in Part 3 by seeing the answers to the quiz posed at the end of Part 3. So for clinical cure of chloroquine-resistant Plasmodium vivax or any uncomplicated Plasmodium falciparum, we saw that the oral 3-day ACT regimens are the recommended treatment. Artesunate Sulfa Pyrimethamine combination treatment is the preferred treatment across India, except in Northeast, where there is a little resistance to sulfa pyrimethamine, which is seen to be emerging. In the Northeast, therefore, Artemether Lumefantrine combination in the ratio 1:6 is the preferred ACT regimen to be used. Artesunate Mefloquine is mainly used in pregnancy, second and third trimester. Age-old quinine, along with doxycycline, also remains the alternative treatment for these chloroquine-resistant Plasmodium vivax and any uncomplicated Plasmodium falciparum, irrespective of the chloroquine sensitivity status. For treatment of complicated falciparum or cerebral malaria, treatment usually needs to be initiated by injectable route, but as soon as the patient becomes capable of being given orally, if artemisinin has been started, the entire 3-day oral ACT regimen is given to the patient, or in case intravenous infusion of quinine has been started, then the oral combination is substituted to complete the total 7 days of treatment. For cerebral malaria, it's important to remember that the Mefloquine combination is not to be used because Mefloquine itself has got neuropsychiatric adverse effects. In pregnancy, if it is chloroquine sensitive Plasmodium vivax, it is a routine 10 tablets course of chloroquine. For Plasmodium falciparum, in the first trimester, quinine clindamycin combination is used, and if it happens in the second or third trimester, it is artesunate mefloquine combination, which is the preferred regimen. If a pregnant lady is residing in highly endemic area for Plasmodium falciparum, intermittent preventive treatment for pregnancy recommends use of sulfa pyrimethamine, 3 tablets single dose with folate supplement. 1 dose given in the second trimester, 1 dose in the third trimester, ensuring a distance of 1 month between the 2 doses. All the guidelines, regimens described in these sessions on malaria are the ones in force in India in 2020, and they're based on guidelines for treatment of malaria, WHO 2015, 2019, and National Vector-Borne Disease Control Program, which is in force since 2016 in India. Before we go on to the details of drugs used, we've seen that the major drugs are those which are quick-acting erythrocytic schizanticides used for clinical cure, and tissue schizonticide, which is required to control relapse in Plasmodium vivax or gametocidal action in the Plasmodium falciparum. So the quick-acting erythrocytic schizanticides that we would be discussing, used for clinical cure or suppressive, some of them for suppressive prophylaxis, are chloroquine, sulfa pyrimethamine combination, mefloquine, artemisinins, lumefantrine, quinine, and atovaquone. Tissue schizonticide Primaquine is the currently used agent for radical cure, prevention of relapse in vivax, and to control transmission in Plasmodium falciparum. Difenoquine, a newer tissue schizonticide, which is useful in a single dose for radical cure, is not yet included in the official guidelines in India. Before going on to seeing the erythrocytic schizanticides, which target the schizons inside the RBCs, let us first see how these erythrocytic schizanticides thrive and replicate inside the red blood corpuscles, the erythrocytes. This will help us to understand the mechanism of action of most of the erythrocytic schizanticides, the anti-malarial alkaloids, prototype being chloroquine. So how do these erythrocytic schizons thrive, develop inside the erythrocytes? The erythrocytic schizons thrive by digesting hemoglobin in their acidic vacuoles. But the process of digestion leads to formation of heme, which is toxic to plasmodia because it can cause clumping of pigments, damage to the plasmodial membrane, and therefore death of the plasmodium. The erythrocytic schizons therefore have a mechanism to convert this toxic heme to non-toxic hemozoin. So these are the basics we need to know to understand how most of these erythrocytic schizonticidal alkaloids work. As I said, chloroquine is the prototype. These alkaloids inhibit the digestion of hemoglobin in the acidic vacuoles. These are alkaloids. They get accumulated in the acidic vacuoles and change the pH of these vacuoles to alkaline side, and this interferes with the digestion of hemoglobin. They are also capable of preventing conversion of heme, which is toxic to plasmodia, to hemozoin, which is non-toxic to them. In addition, whatever heme has been formed, these alkaloids form a complex with this heme, and the accumulated heme and this complex of the alkaloid with heme results in the Seidel effect on erythrocytic schizons. So this is the common mechanism seen to be followed by chloroquine, quinine, mefloquine, and so on. So let us go on to the first drug, the drug which ruled the treatment of clinical cure of malaria for more than 50 years, chloroquine. As we discussed, it's an alkaloid, a basic drug. It concentrates in the acidic vesicles of the erythrocytic schizons, raises the pH, interferes with the digestion of hemoglobin, forms a complex with heme, prevents heme from getting converted into hemozoin, and the heme and heme chloroquine complex is responsible for the death of the erythrocytic schizons. The chloroquine gives quick action and quick relief from fever, quick defervescence within 1 to 2 days. Even the parasites are cleared from the blood smears within, or the circulating blood within 1 to 3 days. It does exert gametocidal action for all the species of plasmodia except Plasmodium falciparum, and therefore it can block transmission except for Plasmodium falciparum. It has, however, no effect on tissue schizons or hypnozoids, and therefore cannot prevent relapse in the Plasmodium vivax or ovale, the relapsing malarias. Resistance to chloroquine has been slow to develop, but now we do see rampant resistance in Plasmodium falciparum, which initially started in northeast part of India. And the mechanism of showing resistance to chloroquine is increased efflux, throwing out the chloroquine from the plasmodial cell, thereby reducing accumulation in the acidic vacuoles of the erythrocytic schizons. If you look at the pharmacokinetics, it is orally effective with wide tissue distribution with high and persistent concentrations in liver and lungs. Accumulation in liver, as we will see, is useful in treatment of hepatic amoebiasis. It has a long T-half, 3 to 10 days, because it is a cumulative drug. And that was useful when it is used as a weekly schedule for prevention of malaria. Adverse effects of chloroquine. The 10 tablets course, as we will discuss subsequently, or we have already discussed, is very safe in pregnancy as well as in infants. Prophylactic treatment, once a week 300 milligrams of base, has been used up to 3 years without any adverse effect. But for indications like arthritis, where it is required to be given for months together, retinal toxicity needs to be kept in mind because it gets deposited in retina and cause loss of vision. Deposits in cornea can also cause damage, but which is reversible. And therefore, to avoid this retinal toxicity, ophthalmic checkup is recommended at initiation of treatment and then in the annual follow-up checkups. It can also cause hearing impairment, graying of hair, myopathy, photoallergy, and mental disturbances in some patients. The other actions and uses of chloroquine are: it is effective for amoebiasis and giardiasis, mainly used for hepatic amoebiasis or amoebic liver abscess with or after metronidazole, where it is requires to be given for 2 to 3 weeks. Even this doesn't cause much problem in the eyes. But anti-inflammatory action made use of in lepra reaction, that is also short duration of treatment. But for arthritis, where it is used for a prolonged period, it needs to be cautiously used because of retinal toxicity, and hydroxychloroquine has replaced chloroquine because it causes less retinal deposits and toxicity. So current status of chloroquine in treatment of malaria in India is: Plasmodium vivax shows only occasional resistance. So for clinical cure of chloroquine sensitive vivax, chloroquine remains the first choice treatment. For prophylaxis, because there is a mix of Plasmodium vivax and Falsiparum across India, it is no more used for prophylaxis. Plasmodium falciparum, where there is widespread resistance, chloroquine is no more used. We do not even bother to assess the chloroquine sensitivity status in case of Plasmodium falciparum. We straight away go to the ACT regimens. Primaquine has a role whether it is a chloroquine sensitive malaria or resistant, not for clinical cure, but for preventing relapse in vivax and prevention of transmission in Plasmodium falciparum. Mechanism of action is different, though it's an alkaloid. Reactive intermediate metabolites of primaquine lead to formation of toxic oxidative species inside the plasmodia. And these toxic oxidative moieties formed inside the plasmodia disrupt the mitochondrial electron transport and thereby disrupt the energy production and lead to lysis of the plasmodium hypnozoites and tissue schizonts. So it's a very effective tissue schizonticide, including hypnozoites of vivax and ovale, and it is also a very effective gametocide, and this action is made use of in Plasmodium falciparum. However, it has a poor erythrocytic schizonticide action and therefore not used for clinical cure. Resistance has not been seen so far. Adverse effects, the important to remember, are attributable to the oxidative property of primaquine. So the important adverse effect is hemolysis, methemoglobinemia. And this hemolysis can occur even at the recommended therapeutic doses for radical cure, that is 15 milligrams per day, in G6PD deficient individuals. In normal individuals with normal G6PD, hemolysis is not likely to occur in less than 60 milligrams of base. The initial manifestation of hemolysis would be dark urine, and if it happens, primaquine has to be immediately stopped. There are variations in G6PD deficiency status, and only certain categories are more likely or at a greater risk of hemolysis. So G6PD status needs to be assessed before initiating primaquine treatment for radical cure. It is contraindicated in pregnancy because fetus is by default G6PD deficient. And it is no more used for causal, it is not used for causal prophylaxis because that would require a prolonged treatment throughout the duration of the stay. So status of primaquine today in malaria is: it is a radical cure to prevent relapse in Plasmodium vivax and ovale. However, this strategy of radical cure should be used only in a patient living in non-endemic area. There's no point in giving this 14 days treatment with a potentially toxic agent when the patient is staying in an endemic area and is likely to get fresh infection from a mosquito bite the very next day. And the dose for this radical cure is 15 milligrams base per day or 0.25 milligrams per kilogram after meals always for 14 days. As a gametocidal agent to block transmission in Plasmodium falciparum, the recommended dose is 0.75 milligrams per kilogram single dose, again given after meals on second day of the ACT regimen. In areas with lesser risk of transmission, lesser endemicity, even 0.25 milligrams per kilogram single dose has been recommended in the WHO guidelines of 2019. And if we are using a single dose of 0.25 milligrams per kilogram as gametocidal agent, G6PD status assessment is not mandatory. However, for 14 days treatment or 0.75 milligrams per kilogram single dose for gametocidal action, G6PD status needs to be assessed, and currently rapid spot tests are available for this purpose. And remember, it is contraindicated in pregnancy because fetus is deficient in G6PD. The first drug, number one choice for chloroquine resistant malaria is sulfa pyrimethamine. You know, folic acid is manufactured by microbes from PABA, para-aminobenzoic acid, first to dihydrofolic acid and then to tetrahydrofolic acid. All sulfonamides, including sulfadoxin, can prevent the step from PABA to dihydrofolic acid, and pyrimethamine, like trimethoprim if you're aware of, can prevent the second step, that is dihydrofolic acid to tetrahydrofolic acid. Both of these drugs, if used individually, can only exert bacteriostatic action, that is, they do not kill the microbes. But the combination used in the ratio, present in the ratio 20:1 in systemic circulation, exerts cidal effect. So the combination is used with sulfadoxin, each tablet containing sulfadoxin 500 milligrams and pyrimethamine 25 milligrams. And a 3-tablet single dose works as clinical cure for malaria. For chloroquine sensitive malaria, but today for chloroquine resistant malaria, it is, and also for chloroquine resistant malaria, but today it is used only as a component of ACT regimen because artemisinin are to be combined with long-acting agents, and both these agents have long duration of action. So they are a component of ACT regimen with Artesunate, which is the number one ACT regimen recommended across India for chloroquine resistant vivax or any Plasmodium falciparum infection. So sulfa pyrimethamine available as fixed dose combination tablets of 500 milligrams and 25 milligrams respectively. The combination works as a fast erythrocytic schizonticide, more against Plasmodium falciparum, even chloroquine resistant Plasmodium falciparum. Some resistance has been encountered as mentioned in the northeast part of India, but there is no cross resistance with any other anti-malarial agent. So for single dose effective in clinical cure, 3 tablets are recommended in adults, 2 tablets in children between 9 to 14 years, 1.5 tablet for children between 5 to 8 years, and half tablet for children from 1 to 4 years of age. It is contraindicated in infants and obviously in patients allergic to sulfonamides. It is the first choice ACT for chloroquine resistant malaria except in Northeast, and the combination is also useful in toxoplasmosis. Mefloquine, the other drug useful in chloroquine resistance, is also a rapid-acting erythrocytic schizonticide, though it is slower than chloroquine and quinine. Mechanism of action is similar to chloroquine, and if it is effective in chloroquine sensitive as well as chloroquine resistant malaria. It also has a long T half and therefore is a useful combination in the ACT regimens, and it is combined with artesunate. Here, with artesunate, mefloquine is given as 2 doses, 750 milligrams given on day 2 of ACT regimen and 500 milligrams on day 3 of ACT regimen. For suppressive prophylaxis, to protect a traveler going to an endemic area, it is used as a 250 milligrams weekly dose, started 1 week before going to the endemic area and continued for 10 weeks after throughout the stay and for 10 weeks after leaving the endemic area. Resistance has started appearing against mefloquine in Gujarat in India and some other countries as well. Adverse effects of mefloquine are usually mild, dose-related. It is also bitter alkaloid and can cause GI disturbance, nausea, vomiting, dizziness, bradycardia. Peculiar adverse effects of mefloquine are the neuropsychiatric adverse effects seen in some patients, which are again dose-dependent and reversible. Loss of balance and ataxia can be dangerous for people with professions like machine operators or drivers. It can also lead to experiencing strange dreams, anxiety, hallucinations. Because of its bradycardia and QT prolongation effect, it is contraindicated with drugs which also have these actions, like quinidine and halofantrine, where the cardiac conduction defects may become more pronounced. It is also contraindicated for patients already having neuropsychiatric problems, like even epileptics or in cerebral malaria. And it is also contraindicated in first trimester pregnancy. Coming to artemisinin derivatives, which was a big breakthrough for management of chloroquine-resistant falciparum. These artemisinin derivatives are the derivatives of artemisinin, which is an ingredient of the Chinese anti-malarial medicine Quinghaousu. Various derivatives have been developed, of which artesunate is the fastest acting derivative, available as water-soluble sodium salt for oral action, oral administration, intramuscular as well as intravenous. Artemether and Artether are lipid soluble. Artemether available orally as well as for intramuscular injection, whereas Artether is only available as intramuscular injection in oil. Arterolane is a synthetic oral derivative, and Artether and Arterolane have been developed in India. All of them are potent and rapid-acting erythrocytic schizanticides with a relative quantitative difference amongst them, and artesunate is the fastest and the most effective artemisinin derivative, the preferred ACT regimen. They have action on all stages of replication cycle of the erythrocytic schizonts, right from ring phase to the early merozoites. They are effective in plasmodia resistant to all other drugs, all other antimalarial drugs. Like we have discussed, there is resistance emerging against sulfa pyrimethamine, mefloquine, and artemisinins work against all these plasmodia. The quick cell kill afforded by these drugs gives defervescence, freedom from fever within 1 to 2 days. But the short action is associated with recrudescence, with lingering parasitemia. The probable mechanism of action of artemisinins, confirmed knowledge is not yet available, is that endoperoxide bridge in the artemisinin derivatives interacts with heme in the parasites and forms a highly reactive free radicals. These highly reactive free radicals bind to the membrane proteins of the plasmodia, cause lipid peroxidation, and damage the endoplasmic reticulum, which gives rise to lysis of these erythrocytic schizonts. Second probable way of action of these reactive free radicals is they inactivate the plasmodial sarcoplasmic endoplasmic calcium ATPase, referred to as Plasmodium falciparum ATP6. So these are the two possible mechanisms by which the erythrocytic schizonticidal action is exhibited once the reactive free radicals are formed. So effect is cidal to all erythrocytic schizons. They are also cidal to early stage gametes, including that for Plasmodium falciparum, but they do not entirely clear the bloodstream of gametes. Therefore, single dose Primaquine is recommended for Plasmodium falciparum to control the transmission even after the ACT regimen, on the second day of ACT regimen. They have no effect at all on tissue schizons or hypnozoids, so they cannot prevent relapse in Plasmodium vivax or ovale. Resistance to artemisinin is not yet seen, and to avoid emergence of resistance and also to avoid recrudescence, they're always used in combination with long-acting drugs, erythrocytic schizanticides. Adverse effects are relatively mild, but they are more toxic than chloroquine. So where chloroquine works, in chloroquine-sensitive Plasmodium vivax, chloroquine remains the drug of choice. Nausea, vomiting, abdominal pain, itching, drug fever, leukopenia, and reversible conduction changes in the myocardium are the adverse effects of artemisinins. Safety in pregnancy is not yet known, so they are avoided in the first trimester of pregnancy. So the status of use of artemisinins in malaria, ACT regimens, combination with longer acting agents, are the drugs of choice for all chloroquine resistant Plasmodium vivax infections, as well as any uncomplicated Plasmodium falciparum infection, irrespective of the chloroquine sensitivity status. We do not even try to ascertain whether Plasmodium falciparum is in this patient is sensitive or resistant to chloroquine. Straight away, oral ACT regimen for 3 days is instituted. Artesunate Sulfa Pyrimethamine is the first choice all over India. Artemether Lumefantrine is the first choice in Northeast India. For complicated Plasmodium falciparum malaria, injectable treatment has to be initiated, followed by complete 3-day oral ACT regimen as soon as oral medication is possible. And the intravenous or injectable drug of choice is intravenous Artesunate. First choice for complicated Plasmodium falciparum. And even when we do give the oral ACT regimen, remember, Mefloquine combination is to be avoided in cerebral malaria. Lumefantrine, orally effective erythrocytic schizonticide with similar mechanism to Mefloquine, has long but slow action, so it cannot be used by itself as erythrocytic schizonticide. It is used in combination with Artemether to prevent resistance and recrudescence. Absorption is better with fatty food. In fact, it is very poor without fatty food. So it must be consumed with fatty food to ensure good effect. Adverse effects, it is better tolerated than this combination is better tolerated than artesunate mefloquine combination. Headache, dizziness, disturbed sleep, arthralgia, myalgia could occur. It uses and inhibits CYP2D6 cytochrome enzyme and therefore can prolong the action of drugs like, say, which need this enzyme, and it also prolongs QT interval, and therefore it is to be cautiously used with drugs which share these attributes. It is contraindicated in first trimester pregnancy and in breastfeeding women. Coming to quinine, which has been described as the first drug introduced in management of malaria. The mechanism of action of chloroquine and quinine is same. It is used in the dose of 600 milligrams 3 times a day, whether orally or intravenously. It is less effective and more toxic than chloroquine, and therefore chloroquine has replaced the use of quinine. But it is still considered important because it is effective against chloroquine-resistant falciparum. Adverse effects are GI irritation. There could be CNS stimulation or depression. It also compromises skeletal muscle contraction. Rapid intravenous chloroquine can cause severe hypotension, cardiac depression, and severe hypoglycemia because of hyperinsulinemia. Hypoglycemia can be seen even with oral treatment, or slow intravenous infusion as is used in complicated malaria. Synchronism is a dose-dependent reversible adverse effect which involves nausea, tinnitus, hearing and visual impairment, diarrhea, flushing, sweating. Hemolysis can occur in pregnant ladies and particularly falciparum patients, but even then it is considered safer than ACT regimen in the first trimester of pregnancy if Plasmodium falciparum infection occurs during first trimester. So current status of quinine in management of malaria is it is effective in chloroquine resistant Plasmodium falciparum in Plasmodium vivax, and it is used in all Plasmodium falciparum cases, but it is second choice to ACT regimens. Oral quinine involves combination with doxycycline or clindamycin to prevent recrudescence. Clindamycin is second choice as an adjuvant only when doxycycline cannot be used, as in case of pregnancy. The quinine clindamycin combination is the drug of choice for Plasmodium falciparum occurring during first trimester pregnancy. For complicated falciparum or cerebral malaria, intravenous quinine is given as slow infusion through 5% dextrose in order to avoid hypoglycemia associated with hyperinsulinemia. Doxycycline, which is the combination treatment adjuvant to quinine, it's a tetracycline, so binds with 30S ribosomes and inhibits protein synthesis. It has a weak and slow-acting erythrocytic schizonticidal action, and it is cidal to all plasmodia, both sensitive and resistant to chloroquine, mefloquine, or sulfa pyrimethamine. It has no action on tissue schizons or gametocytes. Adverse effects, like any tetracycline, are GI irritation, diarrhea, phototoxicity, hepatotoxicity, and it gets deposited in bones and teeth. So because of hepatotoxicity and this deposition in the growing bones and teeth, it is contraindicated in pregnant ladies, also contraindicated in children. And date-barred doxycycline is never to be used. So current status of doxycycline as 100 milligrams per day dose is used in clinical cure as adjuvant with 7-day oral quinine regimen. For suppressive prophylaxis, to protect travelers visiting endemic regions, again the same dose, 100 milligrams per day, can be started just 1 day before, continued throughout the stay, and for 4 weeks after return from the region. Of course, not to be used in pregnancy and children. Clindamycin is the alternative to doxycycline as the combination drug with quinine. It also is inhibiting protein synthesis by binding with 50S. It has slow erythrocytic schizonticide effect in all plasmodia and also multi-drug resistant falciparum. It has no action on tissue schizons or gametocytes, but potentiates anti-malarial activity of quinine and also artemisinin. Adverse drug reactions are rash, urticaria, and GI disturbance. The most serious adverse effect can be pseudomembranous enterocolitis, which is a supra-infection with Clostridium difficile, which can give even fatal outcomes. So current status of clindamycin, it is safe in children in pregnancy, and therefore it is the preferred adjuvant to chloroquine only during pregnancy and maybe in children. So quinine regimen in management of chloroquine-resistant malaria, if doxycycline is contraindicated, uses clindamycin. The latest addition to anti-malarial armamentarium is atovaquone, which is a rapid-acting erythrocytic as well as tissue schizonticide. So these two actions are combined only in atovaquone. It is effective in chloroquine-resistant Plasmodium vivax and uncomplicated Plasmodium falciparum. Mechanism of action is unique. It interferes with ATP generation in the mitochondria. Spectrum is, apart from chloroquine-resistant plasmodia, it is also useful in toxoplasmosis and pneumocystitis jirovecii seen in AIDS patients. Adverse effects are GI disturbance, diarrhea, vomiting, rashes, and fever. It is, being a new drug, still contraindicated in pregnancy. and a fixed dose tablet of atovaquone and proguanil once a day for 3 days is the treatment regimen for clinical cure of chloroquine-resistant vivax or uncomplicated Plasmodium falciparum, where proguanil is combined because it potentiates the antimalarial action of atovaquone and prevents emergence of resistance. So this completes the details about the different individual drugs which are being used in management of malaria. So to just take a very brief recap of the regimens which are based on the national guidelines and the WHO guidelines as discussed earlier. For chloroquine sensitive Plasmodium vivax, it is a simple 10 tablets course of chloroquine, very safe in children and in pregnant ladies as well. For chloroquine resistant malaria, we have oral quinine plus doxycycline or clindamycin 7-day treatment or oral ACT regimen of 3 days, where Artesunate twice a day 100 milligrams for 3 days, Sulfa Pyrimethamine single dose of Mefloquine on 2nd and 3rd day. Artemether Lumefantrine preferred in Northeast. For complicated Falsiparum, injection Artesunate is the preferred injectable artemisinin, and then oral ACT Artesunate Sulfa Pyrimethamine 3-day treatment. For radical cure, Primaquine 14 days. For prevention, Mefloquine weekly or doxycycline daily, started before going to the endemic area and continued throughout the stay and a few weeks later. Pregnancy, chloroquine. Sensitive malaria, it's chloroquine. For resistant malaria, it's quinine, clindamycin in first trimester if it occurs in first trimester, and artesunate, sulfapyrimethamine, mefloquine if it occurs in second and third trimester. Prevention of malaria during pregnancy. If the lady is staying in a highly endemic or high transmission risk of Plasmodium falciparum, is sulfapyrimethamine single dose given once in second trimester and once in third trimester. Whether we use ACT or chloroquine to block transmission of falciparum, single dose of Primaquine is recommended, 45 milligrams. In the latest WHO guidelines, with lesser risk of transmission areas, even 15 milligrams per kilogram, 0.25 milligrams per kilogram is recommended even for the prevention of transmission in Plasmodium falciparum. So this completes our series of sessions on malaria. Happy learning. Thank you.